Good morning, profs. Since I do not have any patient available, I have here my dummy together with a illustration of the lungs, the anterior and posterior part. So let's start. So first thing to do is that I should inspect the shape and symmetry of the anterior and posterior, the transverse uh, part of the thorax, or simply the symmetry of the thorax. And I should compare the size of the anteroposterior from the transverse diameter of the lungs. Because the ratio must be 1:2, meaning to say the size of the anterior and posterior part of the thorax, and that is when doubled, or rather just a measure either of the anterior or posterior part of the thorax. When doubled, it must result to a full length of the um, transverse measurement of the thorax. So now I should check for hmm, this, the posterior axilla in the anterior. If no measurement tools are, or rather if the measure tape is not around, you can use your fingers. See something like that. Okay, it's perfect fit. After that is I then need to check the alignment of the spine, which I need my client to stand up since I'm using a dummy, I'm just going to illustrate how that is going to be. So right here, if this is an actual patient, I need him to stand up so that I can see the alignment. I should make him bow a bit, head down, and the landmark right here is called the spinous or spinous process, which I will use to determine the alignment of the spine. And I must check the three curvatures around the vertebral part, or the vertebral part. Those are the cervical, the lumbar, and the thoracic. Rather, the cervical, the thoracic, and the lumbar part of the spinal cord, the spine. So since this is only a dummy, it's fine. Now let's move on to the next procedure. Since we have started working at the posterior part of the thorax, which we previously did by checking the curvature or the alignment of the spine, I then need to palpate the posterior part of the thorax. Let's proceed in working with the posterior thorax. So, for palpating, if my client has no respiratory complaints, I should rapidly assess the integrity of the whole chest skin and the temperature of it. If my client do report for some respiratory problems, I need to palpate all the thorax, all part of the thorax, and assess for tenderness, the bulges, and any abnormal findings and abnormal movements. If my client somehow have any trauma or uh, fractures around the thorax, I should avoid for deep palpations, for I might cause some bigger problems for my client. So I should palpate in a zigzag manner. One, down, like so. And the next thing that I will do is to check for the posterior, or rather the chest expansion by putting my hands like this, my thumbs together, hands open, and place it at the lumbar area, at the low part of the ribs, like so. If this was an actual patient, I need my patient to do deep breathings, and I should get a normal finding. And how can we determine that? If both of my hands move at the same time and has an equal distance from the spine, like so, my hands should move as my client do a deep breathing. If my client, or rather, if either of my hands didn't move, if this part only moved, or this one only moved, or if my hands did move but the other one somehow weak in expansion, like so, if this only one has a greater mass but this one didn't expand much, or either of the sides, I should take that down or jot that down, for that is an abnormal finding. So the next assessment will be the assessment of the vocal or tactile firmness of the client. If this was an actual patient, as I proceed, I need to ask him to say some words like blue moon, tres tres, 1, 2, 3, or 99 or 99, and I should feel some vibrations as I proceed. So the procedure would be, I should place my palmar side or the ulnar side of my hand at the apex, the mid, or the high part, the mid part, and the low part of the lungs. Or rather, I can do both hands. Like so, and I need to ask my client to say the words that I have mentioned earlier: tres tres, the 99, 99, 1, 2, 3, blue moon, and I should feel the loudest vibration, or rather I must feel the max vibration right here at the top, for this is the apex of the lungs, or the high part of the lungs, a lessened here, and a bit low here, the low part of the lungs. Okay, so if I'm only using one hand, if I'm using only one hand, either of my hand, palmar side or ulnar side, place at the apex. Repeat 99 in a zigzag manner. And I should compare those sounds to one another, if they are symmetrical, or if they're the same, or this one's louder than this one, or this one than this one, or I can just use two hands in doing so. 99, 99, 99. Then I must feel the vibration of my client. Let's now proceed in percussing the posterior thorax. So, if this is an actual patient, I need to ask my client, to fold your hands like this. So, need to fold this right here, like that, so that the scapula is separated for a moment, therefore exposing a lot of lung tissues to percuss. So I need to percuss in a sequential manner, starting from the apex right here. I need to percuss at the ICS, or the intercostal spaces. So this is 1, down to 2, 3, 4, 5, 6, 7, and 8. Down to the other. And 9. There we go. So I should also percuss the lateral side of my patient. Like so. Starting from the axilla, supposedly right here, down to the 8th rib. So this is 1, 2, 3, 4, 5, 6, 7, and 8. Like so. Put it back. So the next procedure will be auscultating the thorax. So I have here my stethoscope, and I must use the diaphragm part of the stethoscope, which is right here. And the reason why we're going to use a diaphragm is so that we can hear or auscultate for the high pitched sound. For this one, here's the high pitched sounds. So I must auscultate in a sequential pattern again, in a zigzag manner, starting at the apex, of course. And if this was an actual patient, I need my patient to take deep, slow breaths so that I can auscultate fully or appreciate fully the sounds that I'm going to hear. I have already cleaned my stethoscope. So I must assess for any abnormal findings, or if there's any, and compare those sounds to one another. Okay, like so. Put on the stethoscope. Check if the diaphragm is the active part. Okay, warm it up. Warm it up a bit using your palms. And auscultate. I should ask my client here to have deep, slow sounds. Like so. Now that we're done assessing the posterior part of the thorax, let's now move on to the anterior part of the thorax. Sir. Yan. So po. I have my diagram of the anterior part of the lungs as well. Like so. So the first thing that I will do is to inspect for the rhythm and the pattern of the breathing of my client right here. The RR, the respiratory rate, and the rhythm. So I should hear only silence and the quiet. I should only hear silence and quiet as my client do reads or do deep readings for me. After that is I need to inspect for the coastal margin, or coastal angle rather. Coastal angle right here. And it should be less than 90 degrees, and uh, the spine, I mean, rather the ribs insert the spine at approximately 45 degrees, and coastal angle, or the widening of the coastal angle is associated with COPD. That's that's an abnormal finding, like so. So just like the posterior thorax, I then need to check for the lung expansion or the anterior respiratory excursion by putting my thumbs like this, open hands, and place it at the lower ribs, lower part of the ribs, at along with in the coastal, with my thumbs along the coastal margins right here, the lines here, and as my client or this one actual patient, I should ask him to do deep breathings again, and I should get a normal finding with my thumbs moving along or separating from each other with an approximate measurement, so usually a measurement of 3 to 5 centimeters of separation, or in other words, or simply terms, the separation must be symmetrical, like so, like this. Okay, as my client do deep breathings, I should get that result. Any asymmetrical findings means that, or any decreased excursion means an abnormal finding. So after that, I need to palpate for the tactile fremitus or the vocal fremitus, just as same manner as we did the posterior part of the thorax. If it so happens that my patient is a female with a large breast and cannot be retracted properly or adequately for palpation, usually this assessment or the tactile fremitus assessment of the anterior thorax is actually omitted. That's only the case. So, again, I need to put the palmar, ulnar side of my hands, or do both. Ask my client to say the words that we have mentioned in the posterior part, at rest, 99, the 99, 3, and I must feel the vibration, and I must compare it to one another to the opposite side. So, 99, right here, 99, lower part, 99. Again, if my patient so happens to be a girl with a large breast, a female with a large breast, and I cannot retract that for I cannot retract that for an adequate palpation. Usually that assessment or this assessment of the tactile fremitus is usually omitted. Again, I must hear the loudest vibration right here at the apex, lessened at the mid, and actually lessened here again at the low part. Now let's move on to the percussion of the ICS. So I must begin here at the clavicles of the supraclavicular space and do percussions. So down to ICS 1, ICS 2, 3, 4, 5. So usually the dullness begins at the the dullness of the sound usually begins at the 5th intercostal space down up to the diaphragm. So let's continue percussing down until the diaphragm level at the coastal margins. Like so, and done. So the reason why the dullness begins at the ICS 5 or the 5th ICS, 5th intercostal space, because the heart is located at the 5th intercostal space. However, it is much more leaned at the left side of our body. And The dullness continues until here for the liver is, or any other organs from the digestive system, is located right here. And the diaphragm is also located right here. Okay. So the last part for the assessment is again to auscultate the uh, breathing patterns uh, of the anterior thorax. You must compare the sounds to opposite sides. And again, I must auscultate in a sequential pattern. Again, but before that, we need to clean the stethoscope. So right after that, put it on. Check if the diaphragm, because we're going to use again the diaphragm part of the stethoscope. We need to ensure that that is the active part of the diaphragm. Again, from the apex. Deep breathings again, slow deep breathings. Next, I must auscultate carefully to hear any abnormal breathing patterns. 3, 5, okay, let's go. Again, if this was an actual patient, I need to ask my client to do deep breathings for me so that I can auscultate properly the deep breath sounds. I should take note of any abnormal findings again for the cracklings, the wheezing, and other sounds that are heard. And nice so. Okay, so right after that, I need to document all of the findings, the time of the assessment, and the evaluations. Uh, I should also evaluate for the following. So I need to check for follow-up checkups. If there's any, I need to do follow-up checkups if there's any deviations from normal are detected, and I should also uh, compare it to the previous assessment if my patient had any. So that's all.